I'm now going to introduce Jan Svensson. Jan is a consultant pediatric surgeon, associate professor, and head of the esophageal atresia treatment center at Karolinska, Stockholm. Jan, welcome.
Thank you, Graham. Thank you, Kex, for inviting me here. I've over the years got a quite strong connection and collaboration with both Kex and EAT and the different parental organization, and actually been able to promote the development of such an organization also in Sweden. So I'm really in favor for these type of organizations and this collaborative work. So thank you very much. So I'm Jan Svensson. I'm a pediatric surgeon running the EA treatment program at the Karolinska University Hospital in Stockholm. And so this is Karolinska. And in Sweden, this centralization process, as you say, has already taken place. For many years, since the late 60s, there's been 4 centers doing pediatric surgery in Sweden, and even that is to some extent centralization, as I realized, compared with Germany in this instance. In 2018, it was the end of a 2-year process supported by the government to go down to 2 centers for these different malformations: EA, anal atresia, congenital diaphragmatic hernia, bladder exstrophy, and Hirschsprung's disease. And then the government decided to put all those things together in 2 hospitals, and all these ones are then now treated in Lund, which is in the southern part of the country, and in Stockholm, which is also south, but not as south. I'll come back to that later in a specific slide. This means that the total caseload in Sweden of around 35-40 cases in a year are now treated in 2 centers, which makes that we consider ourselves being a esophageal atresia center. And being a large hospital and having all these different kinds of pediatric surgery means that we can subspecialize within the department as well. So we have the specializing then in upper and lower GI since a couple of years. And so we have now actually today 3 surgeons subspecializing in EA, meaning that one of the 3 of us is always there, and at some more different cases, 2 of us as well, depending on the training situation. We've been able to formalize an aerodigestive team. I'll come back to that a little bit later, but that also emphasizes the benefit of a center where you could have a team of specialists meeting these patients, because the era of the surgeon as a quality marker or a quality producer, I think, is over. We have an extended transport service that I will also present a little bit later in this talk. We have different NICU, neonatal intensive care unit. We have the pediatric intensive care unit, and we also have an ECMO center at the Karolinska. It's a heart and lung machine, long-term heart and lung machine treatment, especially for children with congenital diaphragmatic hernia. And then, of course, we have a specialized pediatric surgery ward with a high dependency unit on the ward, meaning that the transition from the intensive care unit to the ward becomes more smooth. So then what is a high-volume center? As you said, there is no real high-volume centers in any country in pediatric surgery today. But these are the numbers in Stockholm for the last, since our centralization process back in 2018. And so we have a mean of 18 children each year coming with esophageal atresia. We also have children with long gap esophageal atresia, meaning more advanced reconstruction. We see them every year. And this numbers also means that we are attracting children from other places in Europe and from abroad. But on the historical note, and this will lead back to some kind of conclusion in a couple of minutes, but here is a slide of surgeons. So it doesn't really, this is Boston surgeons, William Ladd and Robert Gross, probably 2 of the more famous surgeons in the world. Robert Gross giving the name for the classification that we are seeing today. He wrote a textbook on this on surgery in pediatric surgery. And there was a lot of emphasis on surgeons because they are the ones who are remembered. These are names that lives on for many, many years. Here are some other surgeons. This guy to the left, he's the reason why there is a parental organization at all, because before he started and before the other guy started, nobody survived. So this was a transition from the survival era to the survival era that happened in the late 30s, early 40s. This was a guy who was the first one who actually made a newborn child with type C EA survive having surgery in the neonatal period. There's a Swedish surgeon there, and also to start the transition to this over to the team approach, nothing of that would have happened without this guy and his supporters, because he was an anesthesiologist. He was actually a dentist who introduced the ether anesthesia. So these guys to the left haven't been able to do their thing if they hadn't been to the guy to the right. And they are just examples, of course, of their whole teams. But this comes from an era where the individual surgeon actually made a difference. And I think this slide shows that. 1935, just taken that as a year. Before that, nobody survived. There was no parental organization. There was no parent organizations of EA because there were no patients surviving into that organization. And as you can see, the transition happened reasonably slowly, but there was still, we counted mortality as an outcome measure in these days. And this is a time where whatever Gross did actually had an influence on survival. And that was the only thing we measured at that time. And that went on even to 1986, or even if when myself would have been born, the likelihood for me surviving this would maybe have been 3 out of 4. And that's survival and nothing else. Today, we do not have these numbers. And as I was sitting here when they had the discussion and realizing that half of my talk was already said when I was listening to you guys, because mortality today should be a really, really poor indicator of quality of care, because you should not die of esophageal atresia. The children that die today, as you said, they die from severe congenital heart malformations. And I think also I would like to add, unfortunately, they do die depending on their genetic conditions. We have trisomy 18 children, we have the CHART children, the ones with severe chromosomal deformities. You do not die from esophageal atresia today. And I wasn't really going to go into, I thought, the numbers of what's happening in other places of the world, rather talk about what's happening in Stockholm. We have the 3.4% mortality, which is quite equal to, I think, to the Boston figures. Anke has shown me numbers from other places as well. You talk about the mortality, there's no mortality difference in France from high or low volume, but it's still 7% in all centers coming together. So it's still a high number. And you said, somebody said here today that the number in Germany is actually 12.4% in a reasonably recent data. And I think this is every single child seen in Karolinska with an esophageal atresia over a 20-year period, including the small newborns and neonates. And to the left, there is children in Boston in the 40s. You could actually see a food pipe on the exterior of the chest on the girl sitting up there on the upper left. These are all well children. These children, they are there's no oxygen support, they have a bit of a food support, maybe some of them. Most of them would have an esophagostomy, having the food coming out on the neck, and then the gastrostomy to feed in the stomach, and that's how they would live. And this all, because I think this shows that in the olden days, the healthy kids, the well children, were the ones who survived. So if you survived, it was because you had a very positive chance of surviving. What Ludd and Gross and Haidt did, they made the healthiest children survive. The rest died. Today, when almost every single child survives that condition, is a transition from mortality to morbidity. And we have sicker kids today. So the children with EA that we see today are sicker. They have more poor lung function, they have more poor heart function, and other problems that they did not have previously because those children did not survive. So that's why we need to change the concept from having a surgeon surviving or saving the life of a child with esophageal atresia to this. This is the team surrounding, and this is I ran out of space on this slide. Even if they made the PowerPoints of today a little bit wider, it's still not enough room for all the specialties that should be on here. But having the patient in the center today, surgeons, ENT surgeons, pulmonologists, gastroenterologists are there as important parts of it. You see the anesthesia theater intensive care, I think, is an amazingly important part of this team as well, because if you don't have them around, you will not be able to do what you need to do to have these kids survive with a good long-term outcome. But you also need all these other things from the fetal medicine, radiology. You need the speech and language therapy to teach these children to learn. And coming back then to a center approach, that if the speech and language therapist do not see a number of EA children every year, the children do not learn to eat. So it doesn't matter if you have a surgeon. You talked about surgeons moving or surgeons going and operating in other hospital, which is a bad idea because the surgeon is one little blue dot on the screen and all the other ones are equally important. So you have the parents there, of course, you have the nursing care. If you have a large volume center, every single nurse on the ward knows how to care for a child with esophageal atresia. It becomes routine. One day you have a pyloric stenosis, one day you have an appendicitis, and then you have an esophageal atresia. And you see them, you treat them, you take care of them, you learn how to handle them. And you see as well in the bottom part of this slide, we have the collaboration with Lund, especially then in regards of EA surgery. So we're a small country. I believe that you should have 2 centers in a country for some kind of competition. We have quite a friendly competition. We do not decide which patients to go where. And we also go to and fro from each other's hospitals and do surgery there as well. You talked about the support of having the cardiothoracic team, which I think is the main drawback from the Stockholm, from the Karolinska. We do not have pediatric open heart surgery there. But then we have the support from the Helsinki team coming to do the autopexis with us. So instead of having a surgeon not doing that very often, then we bring in that capacity, still having the resources around it to care for that child in all other respects. So having a team not only supports the individual patient with the care of the team you have around you, it also makes it easier to reach out and be a part of a global network or a European network of specialists. Here is one example of what you do if you have a large number of patients, if you have a completely qualified team. So this is a quite small child in the theater in Karolinska. We are looking for a refistulation. And this is a child that's spontaneously breathing. It has one metal rod into the airway to look into the airway. And at the same time, we have a flexible endoscope going into the esophagus of the patient. So we can look for this fistula and use all the available modalities to see if there is a problem. And to do that, to have a small child spontaneously breathing at the same time with one pipe in each of these 2 openings, I think it needs quite a lot of collaboration and quite a lot of experience in a team to be able to perform that. Coming to this place, and I think this may be a big part of this. This was supposed to be a quiz, if anybody can see where this is. I tried it on Mikaela, who is the only Swede in the room, and she did not know. Kiruna? This is Kiruna. Thanks. Very impressive. This is Kiruna. Have you been? Have you seen it? Yes. Okay. There's a lot of knowledge in this room. So, sorry? Yes, there's not a lot of knowledge about Sweden. So long train ride to go, but you don't necessarily need to go by train to go to Kiruna, because Kiruna is quite far away. So there is Kiruna on the map. So it's quite far away from Berlin and almost as far away from Stockholm. We said we have Lund in the southernmost part, closing up to Denmark, and you have Stockholm, as most of you probably know, on the right side there, quite low down. And there are children getting born in Kiruna, and there are children with esophageal atresia, with other congenital malformations. They are small neonates born in Kiruna, but they do not have that service in Kiruna. So what do? They travel. Most of them travel to Stockholm. Around 1,250 kilometers, they travel to Stockholm, because that's where there is other so as we showed before, neonatology departments on the way down, but the most severely sick kids, they travel. So the more sick you are, the further you travel, which is a bit of a strange thing. We talked about this in Wrocław, which is in Poland, and to give it an example, if you would have this center in Wrocław in Poland, then you can go to Paris and pick up your child and transport that child to Wrocław to have surgery. And you do bypass, or you fly over a country that we talk about a little bit today. So this means that transport of these children is not dangerous. Transport of these children is not a bad thing. Because what happens if you're going to transport these children at Karolinska. We're very proud. We have this reasonably new. We've been flying different measures before. Now we have this own helicopter. It doesn't really matter. We have a way of transporting people. So once this child is born in Kiruna and they feel that they need support, we bring the Karolinska Intensive Care Unit to Kiruna. So the moment this helicopter lands in Kiruna, it increases the quality of care in that place, because it's like being on the Karolinska Intensive Care Unit. When traveling these distances, it's the most senior pediatric anesthetist intensivists that go with that helicopter. They don't send the young ones away. They have the specialized nurses. We have the possibility to bring an ECMO team and put the kid on ECMO in Kiruna and then take the child back on ECMO to Karolinska, which means that you are increasing quality of care by transporting the children, if you have a transport service that can deliver that care. Of course, you should not put the child in an ambulance and travel it with blue lights through the city on the highway. But if you set up a transport service in the correct way, transport increases quality. We have one of those ambulances as a bus as well, with a similar setup that within an hour or so from Stockholm, we rather go with a bus. But like, we put an intensive care unit on the road. And sometimes we joke about if the ICU would be full, we could actually put one patient on that ambulance just traveling around for a couple of hours until we get to bed, because the quality of care on that transport is equal to it being on the unit. So you cannot state that transporting this child is bad. You can't use the argument the child is too bad to travel. It's too sick to move. That is simply not correct. And then I think this starts with the discussion of mortality and measurement. As we talked about that already, that mortality shouldn't really be a marker of quality of care, because we should be beyond the era of mortality in this series. This was a paper from 2016. It's been from France, and I've seen it in other papers as well. And it's quite remarkable that they did a study on the outcome for the parents and how their psychological trauma. And they said 59% of parents to children with esophageal atresia fulfilled criteria for post-traumatic stress disorder. So they had a PTSD diagnosis, or at least they qualified for that diagnosis, which should be equal to coming home as a soldier from Bosnia or from something in being in that kind of environment, or equal situations. And they have PTSD, and probably a bit more the mothers than the fathers, but still, and it was not really associated with the severity of the child's condition. So in general, just having this child and these problems qualifies for a PTSD in so many cases. And I just would like to finish this by talking about one way to deal with this stress and maybe to decrease this, and what you can do if you have a lot of patients, what you can do to minimize morbidity and minimize this type of problems. We have one special group of patients with esophageal atresia, as I wrote here, when there is not enough tissue. There's a number of reasons why you can end up in that situation. If the gap, the distance is just too wide, there is not enough tissue. In general, if the child is too premature to actually have the reconstruction, that also been learned that in many cases it should be better to wait, not having a surgery when you are 1 kilo or 1.5 kilo, because the consequences of complications is so much more severe. So, or if you have severe cardiac malformations or other reasons to wait for surgery. And then there is a number of things that you can do to treat this. And apart from traction, whatever other way you use, it's a question of waiting. And for that time of waiting, the child should not be able to eat, because there is no esophagus, there is no food pipe. So what we've been done in Stockholm, and what we are very proud of, that we found a way through this. We cheat the children. So here is a group of children in different home environments, whether hens in the garden, out on the boating trip, or in other situations actually feeding. And what all these children have in common, they do not have a food pipe. These kids do not have reconstructed esophagus. So whatever goes into the mouth do not come into there. It does, but it goes out through the way. So we've the sham feeding concept, which is not necessarily new. We've set up a regulated protocol for this, and this is what we do. This is one of those kids with an unrepaired esophageal atresia gross A, blind ending open esophagus, and nothing below. And here that child, he's eating perfectly well, he's bottle fed. Some of these kids eat from the breastfeed. You can do whatever you want. You see it, and this I think is really important in respect of the PTSD, because this is not only getting food into the mouth. This is a parental interaction. This is a mother that can feed her child. You see the child is looking on her mom in a way that we consider would be reasonably natural. He wants to eat, and he eats and he gets full. So he learns satiety. He learns that if he eats, he gets full. And also these kids, they tend to, I do not have any scientific evidence of that. I know that if we feed them like this, if they eat, if they learn to handle a food bolus, they get a good oromotor function. They develop that, which you would not develop if you do not get food into your mouth. So I think these kids are less prone to aspirate. It's less dangerous for them to run around in the garden because they learn how to protect their airway, even if they can't swallow their food all the way into the mouth. You see the concept itself, it's the child eats, the food is taken out from the mouth in the tube and then gets back into the stomach in an equal pace as the child eats. We teach this to the parents, we send them home awaiting for reconstructive surgery. The parents learn to do this themselves without these three people. Even if we say they can't, there are still parents do this on their own. So there's one mother can sit and do this, both feed them, breastfeed them, take the milk out and put the milk back in. So you can do that in any of these given situations as well. And even if this is not a normal situation, it's a normalized situation or it's getting closer to normal than being in hospital bound to the wall with suction pipes and whatever. And instead you can be in these kind of settings. And I think that maybe the risk of a PTSD is less after this, if that still needs to be assessed, of course, scientifically. So with that, coming back to this, I don't think that it's possible to create these kind of teams in a setting where you do one child of EA every 5 years. I think it's time to go away from the idea. Maybe Martin, but maybe not myself. We have their names on a photo or on something on the internet, but that's not important anymore because these surgeons were the ones who changed children not surviving to children surviving, but taking the next step that is not depending on the surgeon. So get the kids into large centers where you can build up a service like this, and I think that will decrease the morbidity over time as well. Thank you very much.
Thank you very much. I'm already very happy with the talks we heard. Because they are definitely different from what we hear usually in the national context on a surgical congress. Just one issue I want to mention as EAT president. Survival is a topic outside our world. In the low and middle income countries, we have countries with 100% mortality rate. So we have to do the one without leaving out the other. And maybe we can learn from the low and middle income country, like we have them in Argentina in our membership and South Africa, what they do to make children survive. And the interesting coincidence between your approach and the one from South Africa, for example, if they have a premature baby which is strong enough to breathe itself, they transport the child on the arm of the mother 800 kilometers from Transvaal to Joburg or Cape Town, and they survive. So there is no high quality or high technique care like you can provide because you save children. They can't be saved in South Africa, but we can learn that a lot more is possible without technique, with the parental relationship and with the warmth of a mother or a father. And so I think this is a very interesting approach of our international collaboration. So we had to change the program here. We will stop early enough to have a few questions about the 2 talks. Graham, we wanted to talk at the end of both sessions about patient advocacy. So now we have to change the program and talk about it now. One you heard already, we represent not only the parents and patients as EAT in Germany, but as well globally. And so we have a lot of more things to do. We want to improve the morbidity in Europe or in the Western world, but we want to increase the survival rates in other areas of the world. And I know that Martin Lacher is one of our allies there as well, doing surgery in other countries. And that's maybe interesting to say, the traveling surgeon might be a first good concept to train the colleagues there before, as long as they don't have the capacity. But what I would wish, Martin, that you train them from the beginning. It's not only the surgeon. Otherwise, they are going through all those decades of discussion that the surgeon is the most important person. So I want to let Graham talk about this.
Okay. So 5 decades from advocacy to co-building. So, the stages of life. This is a different form of patient journey. This is the journey of patient organizations. So, right at the very beginning of this slide, we see in 1980 the creation of the very first esophageal atresia patient organization was actually in Australia. And then we have a few that were started in the early to mid 80s, notably the one in the UK that I'm a board member of, as well as having been involved with EAT, Tufts and CICS. And then we have a few coming along in the 90s and early 2000s. And then we have this cluster which really have come along since we founded our international federation, since we founded EAT. And what has changed along that pathway has been the way in which the patient organizations have worked, and importantly, how they perceive themselves. So at the very beginning, it's been about advocacy. It's about being heard. It's about mutual support. It's about providing the kind of support which we still provide today to new parents and increasingly also to adult patients. And slowly through the years, we moved into a world where we began to engage with medical professionals, not just on the one-to-one basis that you would have as a parent or as a patient, but as an organization. By around about 20 years ago, we started, maybe a little bit earlier than that in the case of some of the older patient organizations, we moved into this world of cooperation. And by cooperation, and I'm going to introduce another 3 C's here, by cooperation, I mean engagement with medical professionals in a way where the objectives and the orientation was still very much about what the patient organization wanted. So it needed some support, for instance, to put together new literature, new information booklets, and so on. That was the kind of first level of that kind of engagement, and that developed into participation in family days like you have here in CICS tomorrow. And as we've moved increasingly through the last 10, 15 years, particularly the last 10, I would say, we've moved into the world of collaboration. And to distinguish between the cooperation and the collaboration, I mean, this is where we're now kind of sitting together with shared objectives. We're sitting there around the table, so to speak, to look for ways of improving care outcomes, helping maybe to implement existing good best practice. And then we've moved along to the co-building. So the 3 C's, the cooperation, the collaboration, the co-building. And with the co-building, we're doing particularly what we're doing in the European reference networks, which is we're now developing new solutions. We're developing new care pathways. We're developing new guidelines, and we're working together on that. The patient and parent input to that process is an inherent part and a crucial part of the process. And this is leading to what we might call in managerial speak, next practice. Yeah. So this is this particular route through the 5 decades of advocacy.
For clinicians, please include the parents as a crucial part. It's not only about the patients, it's about the parents, especially in the early days, because they are treating their child most of the time. And let's learn what I already said from the low and middle income countries. What can we learn to make our health system more cost effective and more parents and patients centered? Because cost effectively, it's not only always a bad thing to do. But on the other hand, I hope many people, many of our patients will listen. We do need more patients. We need especially the adult patients who want to become advocates for their own stories. It's not up to me as a mother to advocate the story of an adult. And we will have tomorrow wonderful success stories of our adults being fathers and mothers, having their families, living their life, and they can tell what were the challenges, but as well where they achieved. Like Graham, he is always our role model. And especially, maybe allow me this, when I go eating with my son and him, I can't decide who is eating the schnitzel faster.
I was eating faster and he was long gap, which is amazing.
And then I invite you all, and we intend maybe a little bit every year. We have our big international global conferences on esophageal atresia. The next one will be April 30th to May 3rd in Istanbul by our lovely colleague Tutku Soyer. So I hope you put it in your agenda. You will join us because this is really worth there. We have all the disciplines together. So, and now it's time for a very short question.
And I would like to just say one thing which you reminded me of there when we were
so then
when we asked about more volunteers from the patient community, particularly adults. Could I also, both in the context of this conference but just generally, please let us know about the colleagues that you have in the adult setting, because we need more specialist adult clinicians to support the patients. We have a cohort of patients, which I think is growing, who have ongoing severe morbidity. Okay, so if you have knowledge of interested adult clinicians, please encourage them to get in touch with us.
Yeah, thank you.
Before the break, we have a little time for questions. Yes, please.
So my question goes to Stockholm. My name is Sandra Bergman. I'm a speech and language therapist. And I was wondering how many hands are necessary to sham feed the children at least? Because I saw there were 6 hands on the baby to sham feed it. And I heard your speech at Breslau in Poland. And I am really fascinated by this. But how many are the least hands? So is it able with 2?
Yes, thank you for the question. And sorry for repeating myself. I thought it was an interesting topic. Yes, I think 4 hands, 2 people should be there. So in what we state in the protocol and what we teach the parents is that it should be two people around. Not necessarily 2 parents. It could be any kind of caregivers. We have single mothers having support by their sisters and other different constellations. And we also know that there are some, I think, only mothers as parents are doing this themselves as well. And the idea is that what we set up is part of this is the concept of satiety, that you try to normalize the feeding situation, that when you eat, you get full. But there is nothing really saying that you can't You can feed the child with a 10, and when you fill a 10 ml syringe, then you give that back into the stomach, and then you do another 10 mils, and then you're good. So you don't need to do that as a circular thing, really. We also, in the protocol, state that we do not want the parents to do this at night. We want everybody to be sharp and alert, and because it's not necessarily every single mean. We know that the parents do that as well. Some parents wake up at night when the child wake up and they breastfeed them, and then they all go back to sleep in more or less like a normal situation as well, and they just do this through the pipe. So normally we'd say there should be two people around. There are people doing it with 2 as well.
And what about the speed to pull out the milk on the upper syringe?
Sorry,
The speed, how fast can you pull out the milk on the upper syringe? I'm wondering about the signs which tell me how fast I can pull the milk back.
I think that it's a learning process, but what we want, so usually the parents do this for maybe 2 weeks in the hospital setting before they go home. So we start to do this, we introduce this idea still when the children are in the high dependency unit, so we see that the child actually can do this and they learn the oral motor function. They move out to their own room, they stay there independently for a week or 2. Some kids that lives further away, for instance in Kiruna, they stay at the patient hotel for a couple of days, and once they usually those steps are taken by the parents because they're ready to go home. They feel that they have a normal child. We have one example. It was obviously a joke, but one family after 9 months, they contemplated not coming back to the hospital because why would we subject our child to this major operation? We're having a perfectly fine life. This is good for us. Why should we subject them to all the risks and complications associated with major surgery? So it can be quite good.
Great, thank you very much.
Thank you.
Nice story. Any other questions? May I ask you, when looking at your numbers, you had like 28 cases in 2018, then 13 cases, 22, 17 cases, 23. So there was actually not a curve you would expect if you centralize a disease. How come?
I think it's depending on the numbers of children getting born in Sweden as a total, because we saw a reasonably similar trend than with Lund. It's reasonably easy for us because we have the total number of patients. Any child with EA would come to any of those 2 centers. And I tell you, in this year, it's an immensely strange year, because until now half the year is gone and we've had 3 children with EA in Stockholm. And there's not been the movement of those kids over to Lund. So I think that's just statistics, and so over time it's been a little bit up and down. But I think there will be a trend of, and we've seen that in Sweden in many conditions, that there is a lower birth rate, and I think it's probably down by 20% over the last 5 and 10 years. So that would actually mean a noticeable decrease in the number of these things as well.
Yeah. Interesting research.
But they do not go anywhere else. I think that's so. It has to be the birth rate statistics.
And the other thing I noticed in your talk is that there's a friendly competition between Stockholm and Lund, and you still travel. And I think there is still room for surgeons travel. I agree the surgeon should not be the factor in the whole thing, traveling, and the infrastructure has to be there. But because the disease is so rare, you still benefit from the surgeon going to Lund, helping out them. Then Lund surgeons are coming to Stockholm. So there is still room for the surgeon traveling between a center with a perfect setup in another center with a perfect setup.
I think that's true. I think it builds experience because, as you said, even with these numbers, with Ying being a large center, there is still 1 or 2 cases of a long gap each year. So I've been in Lund now and doing and assisting or being there in the theater when they do a significant long gap with the experience that I've been building. Once we do jejunal interpositions, that is one of the 2 ways that we treat the reconstructions. Then I have my friend Mikko Pakarinen from Helsinki coming do them. Because he has probably done 25, 30 of those, probably the last larger numbers in Europe. And he can come to us, because we do not fight about the patient. We don't fight who should be the surgeon for this case. It's a long-term outcome. And of course, being a center that can provide all these services, and I don't know if that would be Boston or Cincinnati or any place, but I think virtually any hospital in the world can't have that specific super experience in everything. But if we have if we have the surroundings, we have the ICUs, we have everything set up and an experience. Once we find a surgeon that will be more experienced than us, bring that person in. You should not travel as an experienced surgeon because Mikko maybe should not go to Tanzania because that wouldn't really help the 2 days later when there is a leak or a problem like that. But if you come to a center with a good foundation, then I think there is a definite benefit of keeping surgeons traveling and gaining experience together.
Thank you. Any final questions? Dr. Wilms.
Yeah, as I said in my talk, the data from Sweden will probably not help us to establish a volume outcome relation for EA either, because you are still below 20 cases. But there might be a positive effect of centralization on the financial impact. So is there data about how costly in the whole country of Sweden the care for esophagus atresia was before 2017 and after 2017? That's my first question. And if it doesn't exist, maybe the Keks's 40th birthday is a good day to wish for it, because it could be really helpful. And the other one would be, is there data on job satisfaction of pediatric surgeons before and after centralization? Because, I mean, that's quite a big change, and maybe that data could also help us here in our ongoing discussions.
Thank you. No, we do not have data on any of those two things. We do not have the data on financial things. I guess if we believe that large volumes would increase the quality of care, and that as you said, with an IKEA furniture, to get it right the first time, there is a big movement in the UK of get it GERT or something they call it, get it right the first time. If you take away so many of these complications, because what is costly is to have these kids in hospital months after months after months doing redo surgery, keep them in the intensive care unit, and have the kids that are standard gross C patients having complications and needing to travel. I think that's more expensive. So the major cost efficiency would be taking away these kind of complications. But we do not have any cost calculations. In Sweden, I think most people traveled even before. So there hasn't been a very big change, especially from the northern 50% of the country. These patients travel to Uppsala, which is half an hour away from Stockholm, and have the same airport. So most people travel there anyway. So I think it's quite small change. And what I think also is that from the surgeon's work perspective or work satisfaction, I don't think there is any. I know that this had a large impact on both the centers in Uppsala and in Gothenburg, quite severe implications. And I think it's also an important thing to spread that there was nothing coming out from when they did the data acquisition that they performed worse or so in Gothenburg or in Uppsala. Gothenburg had a really expanded, a lot of thanks to Michaela, who's talk here in the afternoon, research program on EA. They had skilled surgeons, and there was no outcome differences between these two centers. So this selection was not made on too good or too bad centers. It was rather the idea of, if we centralize this, if we increase this volume, maybe we will see a difference in 5 years' time, in 10 years' time, in 20 years' time. But then maybe the numbers are too small. But and it's not like anybody said that the surgeons in Gothenburg were worse surgeons than the ones in Stockholm. There was nothing saying that. But still, the centralization process needed to go through in the benefits of people to come.
Okay, great. This visionary approach, we would need a little bit of that genetic impact in Germany, yes.